Good evening, everybody. Today we're going to talk about renal disease in pregnancy. So what happens in pregnancy in the renal system or in the kidneys? Kidneys, they increase in size, increase glomerular filtration rate and the plasma flow, and there's decrease in the creatinine and the urea, and there's a vesico-urethral reflex, which happens normally in pregnancy. One of the most common things that happen in pregnancy اللي هو urinary tract infection. The most common bacterial infection in pregnancy, it's usually it can present as asymptomatic bacteriuria, and this is the most common cause. Most common organism usually is E. coli. Asymptomatic bacteriuria is more common in African American, in low socioeconomic status, and in multipara. Usually it accounts to about 5 to 7% in pregnancy. The recurrence is usually 30%, and 25% develop symptomatic infection. Complications usually بيكون اللي هو preterm labor, low birth weight, hypertension, anemia, and they can develop pyelonephritis if they're not treated. So numbers you guys need to know is that it's 5 to 7% in pregnancy. The recurrence rate is 30%, and the most common organism is E. coli. Treatment usually is nitrofurantoin, 100 milligrams for 10 days. It's a OD dose. Or you can give a single dose of amoxicillin 3 grams or ampicillin 2 grams. If treatment failure, so if you treat a patient with either of those regimes and she still continues to have symptoms, then you can treat her for 21 days with nitrofurantoin. Suppression, usually you need to treat the patients at the end of the pregnancy with nitro at HS. Acute paleonephritis it accounts for 4 in 100. Usually they present with fever, frequency, flank pain, chills, anorexia, and nausea and vomiting. The organisms, 80% usually is due to E. coli, and 3 to 5% is usually due to Klebsiella. Enterobacter accounts for 3 to 5%, and group B strep accounts for about 10%. Complications, usually it can cause renal dysfunction. It can cause acute acute renal disease, and it can cause endotoxins that can cause hemolysis leading to hemolytic anemia. Treatment, usually you need to admit the patient for IV hydration, acetaminophen for treating the fever. You need to do blood cultures, urine, renal function. You can treat with ampicillin and gentamicin IV for 72 hours, and then you can switch the patient for oral for 7 to 10 days. Repeat blood work in 48 hours and urine test 1 to 2 weeks post-treatment to make sure that the patient is cleared. If no response to treatment in 48 hours or 72 hours, then you need to do an ultrasound to rule out obstruction and stones, or you can do an X-ray. If stone is the diagnosis, then the patient will need a double J stent, treat with nitro 100 milligrams to the end of pregnancy, and you have to know that the recurrence rate of pyelonephritis is about 30 to 40%. Chronic renal disease usually is due to diabetes. That's the most common cause, and it can give you end-stage renal disease in 33% of the cases. Hypertension accounts for 25%, glomerulonephritis accounts for 17%, and polycystic kidney accounts for 15%. To say that you have a renal impairment in pregnancy, mild impairment if you have a creatinine less than 1.5, moderate if the creatinine is from 1.5 to 3, severe impairment when the creatinine is more than 3. So الوحدات اللي احنا عادة بنستخدمها في المستشفى اللي هو 150 is considered mild if it's less than 150. Moderate will be from 150 to 300, and then severe, anything more than 300 will be considered severe. Complications, usually 15% will have impaired renal function, 50% will have worsening proteinuria, and 12% will have hypertension, 50% will have complications related to the hypertension. Dialysis usually during pregnancy is considered when the creatinine is 5 to 7 milligram per deciliter. So in our units, if the creatinine is more than 500, then the patient will be a candidate for dialysis. طبعا all the renal disease, there's increased pregnancy loss. There's the risk of stillbirth, preterm labor, sepsis, premature rupture of membrane. There's risk of IUFD, and early in pregnancy, there's risk of miscarriages and abortions. Pregnancy after renal transplant, so increases the risk of preterm labor, low birth weight, IUGR, preeclampsia, and pregnancy loss. Usually watch for infection and diabetes, especially in patients with immunocompromised. So usually when a patient has a renal transplant, they're usually on medications that suppress their immunity, and they're on cortisone. So prednisone is a risk factor to develop diabetes in those patients. Rejection is usually about 3%. So what do those patients do prior to pregnancy? So they have to have a stable disease for 2 years at least. Stable disease means that her creatinine is less than 150. She's on maintenance dose therapy. No hypertension or easily controlled hypertension, creatinine less than 200, minimal proteinuria or none, and there's no evidence of rejection. So in those patients, you have to treat bacteriuria if recurrent and treat until the end of pregnancy. You have to do liver function, renal profile, CBC, screen for cytomegalovirus and toxoplasmosis and all the TORCH infections. You have to do a drug level. You have to screen for diabetes. If the creatinine is high, you have to rule out a rejection. You have to rule nephrotoxicity from drugs. You have to rule out preeclampsia and paleonephritis. So how do you usually rule out all of those things? Anybody knows? Okay, so ruling out all of those things, you need to do the blood work and you need to do a renal biopsy. In case of rejection or increase of glomerulonephritis, you're gonna find casts in the kidney or in the biopsy. And preeclampsia and pyelonephritis, you're not gonna find them. So polycystic kidney, it's an autosomal dominant. There's 2 types. Type 1, which is 85% related to chromosome 16. Type 2 is 15% and it's related to chromosome 5. Usually they come with flank pain, hematuria, proteinuria, nicturia, and associated with valvular heart disease, mitral valve prolapse. 10% usually die from intracranial aneurysms. So then we have the acute nephritic syndrome. Usually the patients will present with acute glomerulonephritis, which the complaint will usually be hematuria, blood cast, proteinuria, pyuria, hypertension, and edema. The causes usually it's post-streptococcal infection. Patients can have bacterial endocarditis, SLE, IgA nephropathy, membranoproliferative glomerulonephritis, and mesangial-proliferative. Usually, the diagnosis is by renal biopsy. With the IgA nephropathy, you're going to find the immune complex, which is diagnostic in this scenario. And with the others, the biopsy will show you if it's membranous glomerulonephritis or diffuse mesangial glomerulonephritis, depending on what they see in the renal biopsy. Usually the effect on pregnancy is fetal loss, preterm labor, low birth weight, hypertension, and worsening proteinuria. And this can exceed to chronic glomerulonephritis, causing proliferative sclerosing membranous glomerulonephritis and leading to end-stage renal disease. This is a very serious condition and very serious if this happens to a patient before pregnancy. You have to make sure that this patient is on maintenance treatment. This patient doesn't have any medications that can cause congenital anomalies. You have to have a renal function that is less than 200 creatinine, so this patient will be suitable to get pregnant. And you have to transfer this patient to an MFM team and a multidisciplinary team approach in managing this patient. That would include the MFM, the neonatology, and the nephrologist. Then we have the nephrotic syndrome, and usually nephrotic syndrome, you either have the minimal changes, which could be idiopathic or secondary to a viral infection, focal segmental glomerulosclerosis, which can be secondary to sickle cell anemia or hypertension, diabetic nephropathy, and then you have the membranous and the sclerosing. Both of those can be due to connective tissue disease or infection or malignancy. Diagnosis usually is made for nephrotic syndrome with a proteinuria more than 3 grams per day.
دكتور حنين السلايدز ما تتحرك، احنا بقى واقفين على الاكيوت نفروتيك سيندروم.
يعني النفروتيك syndrome I didn't do a slide. I'm just telling you the information you need to know.
Okay.
Okay. So the nephrotic syndrome, the diagnosis usually is with protein urea more than 3 grams per day. Usually they have hypoalbuminemia, they have hyperlipidemia, and they present with generalized edema and lower limb pitting edema. They're at increased risk of thromboembolism. So if a patient comes with glomerulonephritis and she gets pregnant, this patient needs to be on either aspirin or Clexane or heparin. Always remember when you're taking or dealing with a patient that has renal disease, that those patients can present with hypertension or preeclampsia. They can present with worsening proteinuria or renal insufficiency. They can present with anemia, so they have hemolytic anemia due to hemolysis. They usually, the effect of the disease on the pregnancy, it can cause preterm labor, IUGR, low birth weight, and stillbirth, and they can present with end-stage renal disease. Always when you take a history on a patient with renal disease, so you start as your usual, اللي هو your G's and P's, RH status, and GBS, and the gestational age. And then after that, you have to go to your past obstetrical history. So past obstetrical history, you have to take a detailed past obstetrical history That includes the pregnancy outcome, if there was any induction, the weight at the time of delivery, if there was any complications, if this patient had investigations prior, what was the last investigations she had, what was the last ultrasound she had. And you have to always involve your nephrology team in the management of those patients. Type. To make this stick in your head, I have an OSCE. I need a volunteer. Okay, Ali, you have a 33-year-old female with history of renal transplant secondary to SLE. Take a focused history.
Okay. First,
من غير غش.
I will take history the cause of renal transplant.
Okay.
And the duration is now from the renal transplant to up to now.
Okay.
For how long?
Okay.
And from life or life or donation or cadaveric.
ممتاز.
And then any complication occurring as a reaction like that. Okay. And last visit with nephrologist. And now she's, if she's stable, I will see investigation, all investigations is creatinine like that. Okay. There is blood pressure high or not, is blood pressure high control or not control. I review all her medications. Okay. Then I will see if she's stable or not stable. According to this, I will, if a duration more than 2 years or 1 year, consider if stable, all medications on maintenance dose. Then after that, I will ask about any chronic disease other than hypertension, diabetes, like that. Then about last menstrual period, if she is now, which contraception now she's using. After that, I will ask about gynecological history, the cycle, regular, not regular, and STI, any contraceptions, pap smear if needed. If she has obstetric history, previous baby, mode of delivery, especially when this occurring after this renal transplant. Okay. Then if allergic to any medication or now I review all her medication, then I ask about family history about diabetes, hypertension, then social history, and if she's smoking, then after review all, then consider immunization before conception. Now that if she all is stable, then according to the counseling, is very important. The last visit of nephrologist is very important. That I will cancel.
Okay, so this is excellent. طيب. The history you need to know in cases of renal disease secondary to or renal transplant or حتى renal disease in a patient with lupus. أول شيء أنت قلت الduration من متى هي سوت العملية. So the date of transplant. You need to know if the donor is a living or a cadaver. You need to know اللي هو signs of rejection. أنت قلت current medications، قلت follow up with nephrology، قلت recent investigations، قلت اللي هو gynecological history إذا كان عندها اللي هي last menstrual period، إذا كانت على contraception هذه حنرجع لها بس عشان كده كم حاجة في contraception نتكلم عليها في renal disease. قلت اللي هي past obstetrical history، قلت medical history، immunization، وقلت social history. Things that you forgot to mention. طيب. قلت did you mention if the disease is still active or not? انت خشيت في الميديكيشنز اللي هو maintenance وكل هذه الاشياء. ف you need to remember if the lupus is still active or not. لانه lupus per se is a disease on its own والrenal transplant is another thing. طيب. So هذه الأوسكي كأنك انت حتجمع بين اللوبس والrenal transplant. So when you take history, you don't just focus on the renal, you have to include a lupus in your history. Okay?
Okay.
But you have to ask about إذا كان the disease still active. You have to ask about surgical complications at the time of surgery, okay? And the things that you just forgot to mention is the serology, because this patient is post-transplant, so you have to know if she had serology for hepatitis, toxo, and CMV, and HSV, okay? You need to ask also on screening for diabetes. Remember when we said إنه دول البيشنتس بيكونوا على cortisone, and cortisone increases your chances of developing diabetes, so you need to mention that in your history, okay? So other than that, from 12 you got 10, which is perfect. طيب. So Miss S is an nulliparous, had renal transplant in 2007 from a living donor, her father. She has history of essential hypertension, well controlled. She is on AC inhibitor, azoprin and prednisone. Her recent labs test shows that the creatinine is 1.2 milligrams per deciliter, and there's no proteinuria. Will you allow this patient to get pregnant? علي.
Yes, yes, of course.
طيب من الهيستوري هذا اللي أنا قلت لك هو إيش في أشياء ما هي عجبتك فيه؟ So this patient is a nullipara, had renal transplant in 2007 from her father. She has history of hypertension, well controlled. She is on AC inhibitors, prednisone and imuran. Her recent lab test shows creatinine of 1.2 milligrams per deciliter, no proteinuria. So you are going to allow this patient to get pregnant. صح?
Yes, only hypertension control, and the only problem is AC inhibitor. I will change it to
ممتاز. So yes, I will allow this patient to get pregnant, but after stopping the AC inhibitor and switching to another safe antihypertensive medication. Okay? طيب السؤال اللي بعده. What are the criteria for considering pregnancy in a renal transplant patient? Ali.
Criteria, I will check if no rejection within last 6 months.
Okay.
And no hypertension or control.
Okay.
And renal, when do ultrasound, we found no renal, the graph not be abnormalities.
طيب.
And creatinine should be not more than 200 or 2 milligram.
تمام. ايش كمان؟
And then the dose, this immunosuppressant should be on the maintenance, not in the loading dose.
تمام.
And no proteinuria.
Okay. So the criteria usually no rejection in the past 6 months to a year, no recent episode of acute or evidence of ongoing rejection, no changes or increase in immunosuppressive dose, creatinine less than 200 and proteinuria less than 5 milligrams per day, no urinary tract infection, renal ultrasound to rule out pelvic dilatation, or normal blood pressure or minimal hypertension, hypertensive regime to control the blood pressure. Okay. اللي كاتبين MFM و fetal scan هذه بس criteria considering. طيب يعني البيشنت لما تيجي انت من الكرايتيريا اللي قدامك اللي حتشوفيها في البيشنت هذه will you allow this patient to get pregnant or not. طيب غير how you're gonna manage. When you're gonna manage this patient حتعيدوا الكرايتيريا هذه كلها وتضيفوا عليها اللي هو المالتي ديسبلينري تيم. في الهيستوري لما قلت لكم على الكونترسبشن طيب you have to be careful in patients with lupus and contraception. Okay. Estrogen aggravates lupus. Okay. So patients that have lupus they should be on progesterone only types of contraception. طيب فلما في الهيستوري you have to mention انه I would consider اللي هو contraception especially progesterone only methods. طيب يا علي outline الماتernal side effects of the medications that this patient is on.
Okay.
ACE inhibitor.
AC inhibitor, this make renal agenesis, which make causes to oligohydramnios and Potter syndrome,
Okay.
including pulmonary hyperplasia.
تمام.
And the others, all immunosuppression, this diabetogenic,
طب
cause
دقيقة
diabetes.
دقيقة. Prednisone, what are the side effects of prednisone?
Diabetogenic because diabetes, and for baby in long term may causes hyposphagia like that, and IUGR also.
طيب ايش كمان البريدنيزون يسوي في الماتيرنال؟ In general, prednisone, what are the side effects?
Low immune may cause immunosuppression.
ايوه بس what are the other side effects؟ طبعا انت قلت immunosuppression، قلت انه ممكن يسوي diabetes، ممكن يسوي اللي هو weight gain، cushingoid face، ممكن يسوي اللي هو poor wound healing، peptic ulcer، osteopenia. طيب فهذه كلها الاشياء we need to mention it in the maternal side. In the fetal side قلنا اللي هو preterm labor، ممكن يسوي facial midline fusion، واللي هو newborn adrenal insufficiency. في ناس طبعا كاتبين اللي هو الكلفت ليب، صح طبعا الكلفت ليب والبالت ممكن الكورتيزون يسويها. طيب الاميوران، اميوران is it safe in pregnancy؟
اميران is safe.
safe in pregnancy. طيب ايش السايد افكتس حقته؟
I don't know.
طيب تمام. السايد افكتس اوف اميوران انه هو ممكن يسوي انيميا or leukopenia. اوكي؟ طيب Mrs. S is back to see you in a couple of months with a positive pregnancy test. What is your antenatal plan and management of this pregnancy? المريضة حملت and now she's coming back to see you. What's your management plan?
Okay, this needed high risk with consultant and multidisciplinary team, including nephrologist. And then also we see her investigation, this all investigation creatinine, and especially. Then I will see the medication. If she using AC inhibitor, maybe change it to other. Then I will check this if taken folic acid and that. Then I will plan her for all serology for as routine antenatal. Then needed to screen as far as possible for diabetes and for ultrasound dating scan, then anomaly scan in details. Then any visit needed to check blood pressure and proteinuria. I needed to do this all investigations. This monthly needed to blood culture, urine culture, and needed also for creatinine also. And then if any suspicious, we needed to be needed to refer for MFM.
Fine. So a patient like this أول شيء حتقول اللي هو أو حتقولوا multidisciplinary team that includes MFM, nephrology and neonatology. تمام؟ بعد كده إحنا إيش الأشياء اللي نسويها normally في البريجننسي؟ إحنا نسوي dating ultrasound في البداية صح؟ نسوي routine blood work اللي هو البريجننسي routine blood work اللي هي السيرولوجي والCBC والRH status. وبعد كده على 18 or 20 weeks we do the anatomy scan or the anomaly scan. At 15 weeks we do the triple test or the quadruple test. طيب وبعد كده على ال 24 weeks احنا بنسوي اللي هو الجلوكوز challenge test. بعدين at 28 weeks we repeat اللي هو blood work صح؟ و at 36 weeks نسوي GPS swab. تمام؟ هذا لأي وحدة pregnant we do all of that صح؟ فهذه كلها you're gonna mention it. وبعد كده we will add. أنت قلت إنه DC ال AC inhibitor or stop it or switch it to another medication. قلت that you're gonna monitor the kidney status and the immunosuppressive drug levels. طيب اللي هي on it. قلت إنك أنت هتسوي urine culture طيب you have to mention that the urine culture is usually done monthly. Okay. والserial blood work انك انت هتسويها monthly برضو. Okay. بعد كده you're gonna screen for diabetes and infection, you're gonna screen for preeclampsia, and you're gonna do اللي هو CMV and toxo every trimester. تمام؟ أي سؤال إلى الآن على الأوستي؟ طيب. Outline the possible maternal and fetal complications in this pregnancy. علي.
Okay.
لا نروح علي.
Yeah, maternal complication. This is occurring diabetes and hypertension disorder, and including preeclampsia.
Okay.
And maternal also. This complication may later on as preterm labor and may go to.
لا دقيقة. دحين احنا نبغى نتكلم عن اللي هو الماتيرنال أول شيء. preterm هذه considered fetal. طيب. الفيتال حنجي لها. maternal قلت hypertension ودايابيتس. ايش كمان؟
rejection and infection, all infection.
تمام.
And then
هذه البيشنت سوت renal transplant صح؟ ايش ممكن يصير للماتيرنال؟
needed this dialysis also if renal failure can occur.
طيب إذا maternal عندنا hypertension, diabetes, graft rejection. طيب. recurrent UTIs, infections, increased risk of cesarean section. طيب. وممكن المريضة تموت death. اوكي. ايش الفيتال complications اللي ممكن تصير؟
It is maybe IVR, preterm labor, IFD, may need operative vaginal delivery including cesarean section.
طيب.
And this also renal crisis or renal insufficient for babies and care.
طيب. Don't forget to mention congenital anomalies. طيب related to the medications. والشيء الثاني thrombocytopenia برضو ممكن يصير لهم من الميديكيشنز حقت الأم. تمام؟ أي سؤال إلى الآن؟ ما شاء الله الناس اللي بتجاوب في الشات يعني أهنيكم صراحة على إجاباتكم ما شاء الله. وأنت علي you're doing very well صراحة. طيب. Patient is at 30 weeks, presents to the triage with severe headache. Blood pressure is 170 over 110, high creatinine of 2.1 milligrams per deciliter, +2 urine, and red blood cast in the urine. What is your differential diagnosis?
Okay.
So the patient comes with a severe headache, blood pressure 170 over 110, high creatinine of 200, protein urea of +2, and positive RBCs cast in the urine.
The patient should be preeclampsia.
Okay, ممكن يكون severe preeclampsia.
And could be rejection.
Acute rejection. Okay.
There is cast nephritis. Could be nephritis.
طيب يصير lupus nephritis. طيب. مين محمد هذا محمد الشهري؟ Is that correct? في أحد اسمه محمد الشهري؟ مين SHARI؟
Yes, doctor, that's me.
مين دي؟
My name is Shari R5.
Shari, okay. I thought it's Muhammad. It's like a abbreviation for something. What's your name?
Shari.
Shari? You're an R5?
Yes.
Which hospital?
Dalla.
MashaAllah, you are excellent.
Thank you.
I just wanted to say that. Ali, you're excellent, ya Ali. You're doing a good job, ya Ali. But because she's writing in the chat, so I'm just catching what she's saying. But Ali, you're doing perfect صراحة. طيب.
Okay, thank you.
Differential diagnosis, قلنا severe preeclampsia, lupus nephritis, and acute rejection. Okay, so the patient is at 39 weeks. presents in labor, how do you manage her? طب دقيقة دحين احنا قلنا differential diagnosis preeclampsia nephritis or rejection. How do you differentiate between each one? علي.
ايوه
ايوه.
preeclampsia we can case with normotensive and but we do complement maybe
Okay.
differentiate it less slightly.
Okay, ممتاز. Complements in which one is going to be high or low? So complements usually it's normal, صح? If it's low, it indicates something. So when are the complements low? في which one? في اللوبس ولا في الريجكشن ولا في البريكلامسيا؟
اللوبس.
ممتاز. إذن في اللوبس flare, usually the complements will be low. طيب, what's the other thing that you can differentiate all of those?
Also, the preeclampsia may find something, either liver enzyme be high or platelet be low, or we found something to guide us. This is preeclampsia. But we found CAS. This is going with lupus also.
Okay.
And nephritis.
So when they ask you in the exam, how do you differentiate between those three? First, we said the complements. The second thing is the renal biopsy. Okay. So those two are the way to differentiate and to get to your diagnosis. تمام؟ طيب المريضة حقتك يا علي صارت 39 weeks, presents in labor. How would you manage her?
Also, I need a multidisciplinary team, including a physician or nephrologist, and neurologist, and consultant of obstetrician expertise in these cases. Okay. Then I needed to do follow-up routine, this vital sign, at least every 15 minutes, high blood pressure, and we see oxygen saturation, how it's going. Then normal as a normal labor without any intervention, unless there is suspecting something. Otherwise, no indication unless obstetric intervention.
تمام. إيش كمان؟
I needed also fetal monitoring by continuous CTG.
طيب إيش كمان؟
And but we suspect this patient at any time may be dystocia to go to cesarean section anytime.
Okay, so into both multidisciplinary team. Okay, so multidisciplinary team, you're going to include الانستيزيا والنيوناتولوجي والOB والنفرولوجي. طيب بعد كده قلت you're going to aim for a vaginal delivery unless there is an obstetrical indication for a cesarean section. قلت continuous fetal monitoring, وقلت to monitor her blood pressure or to do vitals every 15 minutes. بعد كده الأشياء اللي لازم نسويها in those patients, we need to give them antibiotics. طيب prophylactic antibiotics واللي هو IVF stress dose IV stress dose steroid, لأنه this patient was on oral steroids during اللي هو her pregnancy. طيب ف during labor you have to give her the stress dose of steroid. Okay. The other thing is طبعا انت you're aiming for a vaginal delivery, you can shorten the second stage of اللي هو labor, ممكن تسوي لها اللي هو a vacuum delivery or forceps delivery. Okay, so outline your management plan for this lady postpartum.
Okay. Postpartum also same needed multidisciplinary continue and needed to give the baby for neurology, خليه يعيشوا حياتهم. For mothers, you needed to also to continue follow up her vital sign, including blood pressure, and I needed to anytime also this time of rejection, I needed also to repeat CBC to see W white blood cells and vital sign observation if any temperature high like that, and needed also by nephrologist to if she have medication before pregnancy use as AC inhibitor and came back to the same medication.
Okay.
And as a normal obstetricians as needed follow up for contraceptions and for anti-D if the rhesus negative, if immunization not complete, immunize it. And need to thromboprophylaxis is very important. Consider at least according to her risk 10 days or 6 weeks according to any other risk, and needed to close follow up again with the nephrologist.
Okay. So the plan for postpartum اللي هو no contraindication to breastfeed. Okay. Watch for signs of rejection. Continue immunosuppression. Continue اللي هو renal function monitoring. Involve اللي هو nephrology في اللي هو management حق البيشنت. و don't forget اللي هو contraceptive counseling. Okay. So هذه الأوسكي يا علي كان عليها 50. أنت من 50 جبت 43.
أيوة شكرا لك.
Okay. So excellent job. Organized. Don't forget always in the history you get most of the points على الهيستوري. Okay. So always في الهيستوري ask everything. Okay. So ask things related to your disease, طيب, and ask your normal obstetrical and gynae history, okay? Because what I find sometimes that people will concentrate on the disease itself and then they forget اللي هي normal history. You get points على الهيستوري الثانية اللي هي post obstetrical, post surgical, past medical history, اللي هو social history, family history, medications, allergies. هذه كلها عليها علامة. طيب, if you didn't mention them you lost 7 marks. طيب, فدايما أبدأوا بالهيستوري اللي انتم متعودين عليها, whatever السكيم ولا الطريقة اللي انتوا تبوا تمشوا بيها, وبعد كده don't يعني ask about the normal history and then go into details about the disease عشان لا تروح عليكم العلامات. okay. الشيء الثاني دائما you have to be organized. طيب, شفتوا كيف علي ما شاء الله كان organized في things that he's mentioning. ما في مشكلة أنكم أنتوا تعيدوا الشيء مرتين 3, but always remember that there is a time limit. Usually في الإكزام عندكم 13 minutes. You have to finish في 13 minutes هذه all what you want to say. طيب, الشيء الثالث دائما لما يكون عندكم شيء high risk, don't forget that this is always a multidisciplinary team. You're not going to manage this patient alone. طيب, حتى لما تصيروا إن شاء الله consultants وتكونوا OB, you're not going to manage this patient alone. طيب, you need the help of nephrology, you need the help of neurology, endocrinology, all those people. طيب, إيش في كمان؟ always remember المرة اللي فاتت لما سويت معاكم أوسكيز قلت لكم دائما لما تيجوا تذاكروا حاولوا إنكم أنتوا تذاكروا الديزيز وبعدين تقولوا اللي هو ال effect of the disease on pregnancy and the effect of pregnancy on the disease. okay. احنا هنا ذكرناها. كيف ذكرناها؟ انه لما يسألكم عن الماتيرنال والفيتال complications, so this is the effect of the disease on the pregnancy. The effect of the pregnancy on this disease اللي هو ممكن يسوي worsening of the renal function وممكن يسوي كل الاشياء اللي هي ذكرناها في الكرايتيريا حقت الديزيز. okay. Any questions? Wissam, if she is for cesarean, does the implanted kidney label for injury during cesarean section? Yes, it does. عشان كده لما نسوي لدول البيشنت cesarean section, usually the incision is higher. طيب لأنه الامبلانتد كدني بتكون في البلفس تقريبا. طيب فالانسجن حقكم دائما يكون high عشان to decrease اللي هو الريسك of injury. How can patient with post-renal transplant conceive normally? They can conceive normally. They don't need IVF. طيب. The only scenario where they need IVF طيب إذا كانت المريضة هذه lupus nephritis and she took chemotherapy to treat her lupus nephritis, then she needs اللي هو IVF because the chemotherapy that is used in lupus nephritis is cyclophosphamide, which affects the gonads. Okay, so if she didn't do any preservation before starting the chemo, she might need IVF. But usually, as Faisal mentioned here, that those patients usually can conceive, 5 to 10% chances of conceiving normally with no issues and with no complications during pregnancy. Complements is high or normal in preeclampsia. So complements usually are normal. طيب. They're only low in lupus.